Dear Volker, dear colleagues, thank you for letting me talk about techniques, pitfalls, and revision strategies concerning the lateral approach to the SI joint. I used to be an investigator in the IMEA trial. When talking about the technique, it's important mainly to have a lateral view at the beginning of surgery, mainly to see this structure here. This is the alar line. It is the most cranial border of the sacroiliac joint. As most of you are aware of, it's quite difficult to actually see the sacroiliac joint on a lateral view, so this alar line is quite important for orientation. Of course, we need an inlet view. This is mainly to show us the anterior border of the sacrum, and an outlet view to identify the foramina on both sides. Before we begin, we mark the alar line to identify the joint and the positions of the implants, and then we make our skin incision. The first step of surgery then is to advance the soft tissue protector, and through this protector we advance the pin. Both of them should be firmly engaged with the ilium, and then through this trajectory we can then drill, and with this drill create a canal with which we can advance a broach and later on place the implants. This is the lateral view. Surgery itself is simple, usually between 30 and 45 minutes, depending on how many implants you have simultaneously placed per view. And this is the third implant going in most distally. One of the most important pitfalls is that it may be difficult to identify the alar line and to superimpose both alar lines on lateral view. Again, anatomically, I've already explained, the alar line is the upmost border and an important identifier to the SI joint. Now, if you initially position the patient, usually you see a doubling of this alar line. Now, simply reposition the pelvis of the patient a bit to make sure that these two lines become one, and then you will definitely have better orientation for the joint. Now, there are some cases that are quite tricky. Here you see on the right side there is a dysplasia of the alar. Now, if you think this is a rotational effect, then you look at the axial slides as well, and here you can definitely see the anterior part of the right alar is not present, so it will be difficult to reach a nice doubled alar line here. So pre-op imaging, analyze. If you have an MRI, you can often already see this on MRI, and if needed you can add a CT scan, which will make dysplasias more clear, and if needed for such cases navigation comes in quite handy. Another important pitfall is potential perforation into a sacral foramen, especially second and third implants. They do get close to the foramina. As we see here, the first implant is way above the first foramen, so it's not really in danger of getting close. So if you get close to one of the foramina, then you may want to switch to a blunt pin to prevent it from entering, or if you have already entered, definitely change to a blunt pin to reduce trauma on the nerves. Another pitfall that is important, sometimes the pin gets stuck to a drill, as it also can come out with the drill. So this is unfortunate, especially since we do want to continue broaching and implanting via this pin. So what I usually do is use a larger pin that is blunt to position it through the drill, and thereby keep the shorter pin in position. You can also ask the nurses to flush the drill after each use to clear it from debris, and also, if nothing really helps, just exchange the drill and the pin altogether for a long blunt pin, which can be positioned via the soft tissue protector. Usually not a problem. Another pitfall that is important, when it comes to the second implant, usually the sacrum can get quite thin and potentially fracture. This is what I mean. This is comparable to an inlet view. You see that the sacrum is quite thin to advance the implant at a position like this, if you start out with the surgery, there's some type of instinct to say, well, in this situation, maybe I should not drill too much into the sacrum or broach too much into the sacrum because it's so thin here. Maybe I may break it with the drilling. However, the opposite is the case. If you do not drill or broach thoroughly in this thin sacrum, the implant, once it gets advanced, will not be able to enter the cortical region of the sacrum, and therefore keep on pushing against the sacrum, and then I think fractures are more likely than if you broach or drill. So really important, make sure you drill and broach well into the sacrum, even when the sacrum is thin. Now, revision strategies, actually, when do we revise? Typical reasons are perforations of an implant into a foramen. Now, we observed a prevalence of this of 0.5% in IMEA, and of course, in case of implant loosening, this we observed in 4% of all implants, and this is what it usually looks like. Usually you have a halo in the sacral area because the ilium bone is usually quite strong compared to the sacrum. Since the implant is usually quite firmly attached to the ilium, it's not that simple to just pull it out. The company provides a special explantation kit because you actually cut out the implant from the ilium. I'll explain. You use a soft tissue protector through which you advance a guiding rod which is screwed into the implant to be explanted, and then there's a blade to fixate this structure to the bone, and then you can advance 3 chisels through this guide, one on each side of the triangular implant. So with these chisels under fluoroscopy guidance, you actually cut out the implant, and of course the result is that the hole that you create with this explantation is actually larger than the implant itself. So you use the slotted mallet to explant in the end. This is a revision case in which there had been a Diana infection and explantation, and then there was an eye fuse conducted, and here we see the bony defect of the formerly positioned Diana. And the first implant is actually nice, but these 2 implants here are actually just hanging in mid-air, just in the section where the Diana used to be, so they don't really give much stabilization support. So this is the image. Our strategy was either explant these 2 ineffective iFuse implants, and I said before, this is quite traumatic, so we do create a hole into the SI joint, which may actually not be beneficial as well. So we decided to actually add 2 implants anteriorly, 1 and 1 posteriorly. This is the post-operative image, so this is a nice position. This is the lateral view on 3D. The upmost 3 implants are the ones that had been implanted prior to our revision. Now we have added the ones on the lowest border, and just to make this a little clearer, now the patient has 5 iFuse on one side. I'd like to show this video here. So we rotate and we see that these 5 implants are placed well, and on the other side there still is a Diana, so this patient is a true hybrid. Now the key points I'd like to make are definitely get a good lateral view intraoperatively, mainly to superimpose the alar lines for orientation. Definitely try not to enter sacral foramina, and when revising, decide between explanting versus adding implants. Special thanks to Bengt Sturesen, who was my teacher and 8 years ago showed me how to conduct these approaches to the SI joint. And this is the place I work at. I would like to thank my team, and if you have any questions, I'm happy to answer them. Thank you.